Welcome again to the second part of the neurological disorders. The cranial nerve lesions. Cranial nerve lesions may be affected by systemic cause like diabetes mellitus or multiple sclerosis, or there may be a local cause. The onset may be acute like in infections such as polio, or can be chronic like in tumors of the posterior cranial fossa as an example. Bulbar palsy. Bulbar palsy is a condition where there is multiple cranial nerve pulses. Taking more than one cranial nerve is affected. For example, the tongue, there is a problem with the movement of the muscles of the tongue, plus the muscles of chewing or swallowing, plus the facial muscles due to loss of function of the motor nuclei in the brainstem. And the cranial nerve lesions, we know that we have 12 pairs of cranial nerves, starting from the olfactory till the 12th cranial nerve, the hypoglossal. And for each nerve, we have to see what is the possible problem and what is the sign resulting from this cranial nerve affection. For example, in cranial nerve 1, the olfactory nerve, the possible problem can be due to trauma or tumors, and the sign is decreased smell. In optic nerve, the possible problem is trauma, tumor, multiple sclerosis, or stroke, and the sign is blindness or visual field defects. Cranial nerve 3, the oculomotor, the possible problem, diabetes, increased intracranial pressure, and the sign dilated pupil and ptosis, and so on in the 12 cranial nerves, trigeminal, abducens, facial. We see the cranial nerve, the possible problem, and the sign resulting from the affection. These are the 12 cranial nerves, starting from the olfactory cranial nerve number 1 and ending with the hypoglossal nerve, which is the cranial nerve number 12. Continuing the cranial nerve lesions, the vestibulocochlear, the glossopharyngeal, the vagus, the accessory, and the cranial nerve number 12, the hypoglossal, the possible problem, each one of them, and what are the signs resulting from this cranial nerve lesion. The trigeminal nerve, or cranial nerve number 5, we know that it divides into 3 divisions, the ophthalmic, maxillary, and mandibular divisions. And these divisions may be compared by testing the skin sensations on either side with a piece of cotton wool. Also, the corneal or the blink reflex is often the first clinical deficit to be seen in trigeminal nerve lesions. So we test for the sensory part of the trigeminal nerve by cotton wool, comparing sensations in the forehead for the ophthalmic, on the cheeks for the maxillary division, and on the sides of the oral cavity over the mandible for the mandibular division. And also we test for the sensation by the corneal reflex using a cotton wool. Testing the motor division of the trigeminal nerve, we ask the patient to clench and press on his teeth and palpate the masseter muscles. If the motor division of the trigeminal nerve is injured, the masseter on that side will not be contracting properly. Also, we ask the patient to open his mouth. If there is a unilateral lesion, the mandible will be seen to deviate towards the weak side due to paralysis of the pterygoid muscles. We test for the motor division by feeling the masseter muscle, like in the picture, in the upper right picture, and in the lower right picture we ask the patient to open his mouth, and if there is an affection of the mandibular division, we will find that the mandible deviates towards the weak side. Ramsay-Hunt syndrome. This is a facial paralysis, but it is accompanied by other symptoms. It's a facial paralysis of lower motor neuron lesion like Bell's palsy, but it is accompanied by vesicles in the ipsilateral pharynx as well as in the external auditory meatus. And the etiology is herpes zoster infection of the geniculate ganglion of the facial nerve. Infections of the nervous system, like meningitis for example, the manifestations are severe headache, vomiting, and often drowsiness up to loss of consciousness. There's painful stiff neck, and aversion to light. Bacterial meningitis can complicate maxillofacial injuries of the middle third of the face in the dangerous area, and this needs prompt use of prophylactic antibiotics. Brain abscess may be secondary to oral sepsis or infection elsewhere, like in the middle ear or in the paranasal sinuses. Cerebral palsy is a disorder of the motor function due to cerebral damage. It is usually associated with birth injury or hypoxia during childbirth, and this is the most common cause of a congenital physical handicap. It may be associated with epilepsy. Cerebral palsy is of three subtypes: the spastic type with spasm of the muscles, the ataxic type with disturbed balance, and the athetoid type with writhing movements. Also, there are associations in the oral cavity, like dental malocclusion, abnormal movement of the oral and facial muscles, and these abnormal movements of the oral and facial muscles may cause difficulty in the dental treatment under local anesthesia. So local anesthesia might not be tolerated, and general anesthesia may be the only way to treat these patients. Anxiety worsens cerebral palsy, and so we might think of a pre-medication, like for example with diazepam before the dental treatment. Horner's syndrome. Horner's syndrome, there are 4 signs. First, it is due to interference with the cervical sympathetic chain in the neck. And the 4 signs are constricted pupil, ptosis, which is drooping of the upper eyelid, like in this patient's right eye, loss of sweating on the ipsilateral face, and enophthalmos. And it is caused by cutting or interference or injury of the cervical sympathetic chain, like after surgical radical neck dissection, like after neck traumas or accidents, or by tumors. Thank you very much.